Now we would like to start Morning Seminar 1, sponsored by Gilead Sciences. The chairperson is Dr. Hidekatsu Kuroda, specially appointed professor, Division of Gastroenterology and Hepatology, Department of Internal Medicine, Iwate Medical University. Dr. Kuroda, please start.
Thank you. Good morning. Welcome to this session. This session morning seminar 1 sponsored by Gilead Sciences. I'll be chairing this session, Hidekatsu Kuroda from Iwate Medical University. The presentation is about the paper entitled A New Era in Liver Diseases, Recent Advances and Issues in Hepatitis C Virus Infection and Liver Cancer. This paper will be presented by Dr. Jun Inoue from Tohoku University. His major is molecular biology of hepatitis. Dr. Inoue, as you know, a good-looking guy and leader of Tohoku area. Okay, and now please give us your lecture.
Thank you, Dr. Kuroda, for the kind introduction. I'm Jun Inoue from Tohoku University in Sendai. I appreciate the President, Dr. Ueno, and all the staffs in this meeting. The topic of my talk is hepatitis C virus today. This is my COI. I'd like to talk about these contents: recent epidemiology of HCV and liver cancer, treatments for HCV infection, and issues in post-SVR patients, including HCC, and challenges toward elimination of HCV. Hepatitis virus is round-shaped and the diameter is about 60 nanometers. And it's present in the blood with lipid, and this is called lipoviral particle. This cartoon shows the life cycle of HCV. The lipoviral particle attaches on the surface of the hepatocyte and enters into the cytoplasm, and HCV RNA is released and translated and packaged and then released. There are several steps of the replication, and the RNA replication step is the main target of antivirals. This is a history of HCV. In 1970s, HBV and HIV were identified, and non-A, non-B hepatitis was proposed, and in 1989, HCV was identified. And hepatitis induced by HCV was proved. And then analysis of infection and replication of HCV was progressed using this experimental model. And using the model, antiviral drugs were developed. So these three doctors were given the Nobel Prize in 2020, as you know. This map shows the dominant etiology of cirrhosis by country. The red country is alcohol-dominant country. South America and major part of Europe is alcohol-dominant. And blue country is hepatitis B dominant, main part of Asia and Africa. And the yellow part is hepatitis C dominant, North America and some part of Europe, Africa, and some part of Asia, including Japan. This data is from cancer incidence in 2020 estimate. Then the female breast cancer ranked first, and lung cancer, prostate cancer, non-melanoma skin cancer, colon cancer, gastric cancer, and liver cancer following. So the liver cancer is the 7th most common cancer in the world. Regarding cancer deaths, liver cancer is the second leading cause of cancer death after the lung cancer. So the burden of liver cancer is very huge in the global. As you know, HBV and HCV are cause of HCC, and this graph shows the increasing number of patients who developed HCC from 2050 and 2030. So HCV-related incident HCC cases were increased in 6%, and HBV-related incident HCC cases were increased 33%. Regarding the incidence rate, HBV-related HCC is estimated to increase 10%, and HCV-related HCC is decreased in 12%. But the reduction is very low. So the curative HCV treatment is key driver of the decreasing HCV-related HCC incidence rate. WHO has set an objective to eliminate HCV infection by 2030. So diagnose 19% of patients with chronic HCV and treat 80% of patients diagnosed with HCV. These targets are set to minimize new chronic infections and decrease HCV-related mortality. Some countries are on track for the goal of WHO. Spain, Norway, Australia, and so on on track for the goal, including Japan. South Korea is estimated to reach the goal in 2032. However, United States, regarding United States, the goal is too far in the estimation. As you know, COVID-19 had a great impact on the elimination strategy of HCV. This estimation shows new diagnosis was decreased, new treatment starts were decreased, and incident of HCV, liver-related death, incident of HCC, and viremic infections were estimated to increase. So now in post-COVID-19 era, so we have to enhance elimination strategy. This figure shows the change of numbers of HIV-infected patients by country from 2050 to 2020. The broad bar shows patient number in each country. China, Pakistan, India, Russia has still many patients of HIV infection. Interestingly, in Egypt, the strategy was successful and many patients were already treated and cured. Also in Japan, the strategy is relatively successful and the rank was going down. This map shows DA treatment rates in each area. So the dark area shows more than 60% patients were treated with DAA, including South America, Africa, and Australia. Also in Asia, more than 60% patients were already treated. But in North America and Europe, the rate is less. As you know, liver fibrosis progression is more rapid in elderly patients. This graph shows if the patients were infected HCV at older age, the fibrosis more rapidly progressed. So the aging, in other words, senescence, is very important in the HCV infection. Also, steatosis enhances liver fibrosis in HCV-infected patients. If the patient have more than 30% steatosis at initial liver biopsy, more than 30% patients developed progression of liver fibrosis in 6 years. So we have to care also steatosis in HCV-infected patients. Also, HIV enhances liver fibrosis. So in HIV and HIV co-infected patients, as high as 69% patients developed cirrhosis in 25 years. This cartoon shows the factors associated with severe liver fibrosis in HCV patients. As you know, unhealthy alcohol use is a big risk factors for the severe liver fibrosis, including past alcohol use. And diabetes has a odds ratio of 4.27. And unemployment and low education level were also reported to be associated with liver fibrosis. As protective factors, coffee intake was reported to decrease liver fibrosis. The odds ratio was 0.42 per cup per day. So if you take a cup of coffee per day, the fibrosis risk is reduced almost half. And also HCV cure is a very big effect for the liver fibrosis reduction. This figure shows HCV protein promote HCC and fibrosis. HCV proteins have effect on cell proliferation and inhibit apoptosis, and core protein dysregulate lipid metabolism. Also, angiogenesis, epithelial mesenchymal transition were promoted by the HCV proteins. And also loss was induced. Then the steatosis and fibrosis was progressed. And also loss induced genome instability mutations. So this instability also progressed HCC. So HCV is a very big inducer of liver fibrosis and HCC. In chronic liver disease, vicious cycles of senescence was formed. Real and oxidative stress induce cell damage, compensatory proliferation, telomere shortening, and leading to senescence. Senescence induces SASP inflammation. SASP is senescence-associated secretory phenotype and induce inflammation, and this is a cause of ER and oxidative stress. And senescence induces metabolic dysfunction, leading to lipotoxicity and ER and oxidative stress. So such as cycles is formed in HCV-infected patients. Also, HCV promotes systemic metabolic dysfunction. HCV proteins induce lipid uptake, lipogenesis, and gluconeogenesis, and cause steatosis of the liver. And via pancreas, HCV indirectly induce glucose metabolism impairment in muscle. And also in adipose tissue, the metabolism was affected. HCV affects not only liver, but also several organs. HCV is known to induce cryoglobulinemic vasculitis, B-cell lymphoma, cardiovascular disease, type 2 diabetes, and chronic kidney disease. Such extrahepatic manifestations are progressing along with fibrosis of the liver. So this affects the survival of the patient. Recently, I saw double rainbows on our hospital. So I felt something good will occur, but nothing good so far. So I'd like to introduce Japanese guideline of hepatitis C treatment for participants from other countries. So if the patient is chronic hepatitis or liver cirrhosis, Harmony, Margaret, and Epiclusa were recommended. If the patient has decompensated liver cirrhosis, Epiclusa is recommended if the Child-Pugh is B. Also, in Child-Pugh C patients, Epiclusa is recommended, but hepatologists should consider the application. And option of watch and wait is described. This is a guideline for the case with failure for DAs. In these patients, Epiclusa and Margaret were recommended, and the choice of treatment by hepatologist is recommended with a consideration of resistance-associated substitution, RAS, in NS34A, 5A, especially P32 deletion. This is data from treatment centers for liver diseases in Japan regarding RAS frequency in patients with treatment failure for HIV. L31 and Y93 substitutions were frequently found, and some other RAS were found. Regarding P32 deletion, almost 4% were found. I think this is not low. So we have to care P32 deletion. This is a real-world data of Sohbel Epiclusa. This is effective in genotype 1 to 6, and also effective in each fibrosis stage from F0 to F4. So this drug is pan-genotypic and pan-fibrotic. Also, Epiclusa is effective in patients with various backgrounds, like intravenous drug users, PPI users, and any treatment histories. This is an optimal flow of diagnosis and treatment for hepatitis C. HIV antibody should be checked in medical checkup in local government and workplace, or pre-operative tests. And if the test was positive, the patient should be consulted to specialist. And if the HIV RNA was positive, the therapy should be performed. And after SVR was obtained, the patient should be followed up according to the event risk. However, HIV antibody positive patients do not always return for follow-up PCR testing. So such a simple strategy is suggested in global. I think in Japan, such a simple treatment strategy is not needed, but some countries, if the treatment is not progressed, this simple strategy is needed. In our first days, the test and treatment was started. And after SVR, just confirm cure after 12 weeks. In this report, using software, minimal monitoring strategy was performed in these 5 countries. In this strategy, there was no genotype check, and only phase 4 was assessed. And all tablets were prescribed at the initial visit, and remote contact at week 4 and 22 for SVR scheduling. There is no on-treatment clinic visit. As a result of the strategy, 95% SVR was achieved. So such a simple strategy is effective. Also, in Singapore, such a simple monitoring is tried. At the first visit, treatment was initiated, and after the treatment, SVR20 was checked on the second clinic visit. As a result, SVR12 was 99%. It was same as standard care. So such a simple strategy was proved to very effective. In such a simple strategy, the assessment of DDI, drug-drug interaction, is essential. This data shows drug-drug interaction with DAAs in patients with HCV. In DAA-treated patients, several patients were treated with another drugs with potential interaction with these DAAs. And these data from database and from pharmacy shows the software have low interaction with the drugs. So software does not contain protease inhibitor, so this is less interaction with other drugs. This paper from Germany shows increasing number of patients were prescribed with more than 8 drugs at baseline from 2040 to 2080. So there are many patients prescribed with other drugs, and also this data shows software has less drug-drug interaction with other drugs. The benefit of HCV eradication depends on the degree of liver disease progression. If the patient has chronic hepatitis, the benefit of SVR is large, but if the disease is progressed, the benefit becomes small. If the patient have decompensated cirrhosis or HCC, even in these patients, SVR reduces further decompensation and improves survival. However, the reduction of HCC recurrence or occurrence is still questioned. This cartoon shows change of FIB4 index, RB score, and MELD score during the progression of liver disease. FIB4 index is increasing from the early stage of liver disease, and RB score is going up rapidly at the pre-cirrhotic stage. And MELD score is increasing at the last of cirrhosis, Child-Pugh C stage. So we should use these scores in appropriate stage. This is data of the Sohbel 12 weeks for the decompensated liver cirrhosis. This data shows SVR improved Child-Pugh grade and also modified RB grade after the SVR 12. Also, this data from Osaka University shows SVR 90% was obtained even in decompensated patients. After the SVR, the Child-Pugh grade was improved in these patients, and significant increase of serum albumin was obtained, regardless of the albumin level as the baseline. And such a decompensated patient is considered for the liver transplantation. So when the DA treatment should be performed before transplantation or after transplantation. This data shows it depends on MELD scores. If the MELD scores is less than 18, DA therapy should be done before transplantation. And if MELD scores is more than 20, the DA therapy should be done after liver transplant. And if the MELD scores between 18 to 20, these factors should be considered. Diagnosed HCC, genotype of HCV, and waiting time. As potential issues of DAA after HCC therapy, an expected high rate of early tumor recurrence in patients with HCC treatment history. This paper shows after the DA treatment, the black bar indicates DA initiation to HCC recurrence. So there was many patients with early recurrence after DAA treatment. However, several following studies shows DAA does not increase HCC recurrence. In this gastroenterology paper, there was no impact of DAA therapy on HCC recurrence and also early HCC recurrence. And a similar result was obtained from meta-analysis. So we can use DAAs after HCC treatment safely. Also, in HCC patients, if the HCC was treated in early stage, BCLC stage 0 or A, with curative rejection or aberration, DAA reduced the risk of HCC progression. This data shows DA treatment in the DA treated group, the tumor progression was reduced and also liver-related death was reduced. So the DA therapy after HCC treatment improved survival. However, it is still questioned whether DAA is effective on survival in patients with active HCC. This is an ongoing question. Also, HBV eradication induces HBV reactivation. From this APAS guideline, in HBs antigen positive patients, 41% patients experienced HBV DNA increase. And HBs antigen negative and antibody positive patients, 0.91% patients experienced HBV reactivation. So in this guideline, if the patient has HBV DNA or HBs antigen and advanced fibrosis or cirrhosis or HCC history, preemptive nukes is recommended. And if the patient have no advanced fibrosis, cross monitoring for HBV reactivation is recommended. Why is HBV reactivated after HBV eradication? So this paper shows the DA treatment reduced interferon responses, resulting in HBV increase. In the double infection model of HBV and HCV using mouse model, after the DA treatment, the HBV RNA was disappeared, and after that, HBV DNA was increased. After DA treatment, interferon response, like chemokines, was reduced. So these are the cause of HBV reactivation. Not HBV reactivation, but we experienced HBV reactivation patient. HBV reactivation is relatively rare, but if viremic patient was treated with immunosuppressants, HBV can increase. In this intestinal pneumonia patients who were administered for steroid, after the prednisolone treatment, the green line, HBV RNA, was increased and also developed icterus. After Harvoni treatment, the HBV RNA was disappeared once but relapsed. And after that, Maviret was prescribed and SVR was obtained. So we have to care such patients. These are deers in Nara and great Buddha. And there was a hole, one was a pillar near the Buddha. If you can go through the hole, bad things are believed to go away. So if you visit Nara, please try. HBV eradication reduces the occurrence of HCC, but not completely in interferon-based therapy and also interferon-free DA therapy. And this meta-analysis shows patient, if the patient is cirrhosis, 2.99% per year developed HCC. And if the patient have F3 fibrosis, 0.63% patients developed HCC. And if there is no cirrhosis, 0.47%. So after SVR, the patients have also risk of HCC development. So why the HCC develops after the SVR? This gastroenterology paper shows HCV-induced epigenetic changes persist after HCV eradication. So this mechanism is thought one of the reasons of the HCC development. And hepatocellular organella abnormalities persisted after HCV eradication. In this electron microscopic picture, there was abnormalities of mitochondria and ER was found. So these organella abnormalities also the cause of carcinogenesis after SVR. Then, who and how long should we survey for HCC after SVR? This is a recommendation from EASL and ASLD. In EASL recommendation, if the patient has F3 fibrosis, the surveillance of HCC is recommended by ultrasound every 6 months indefinitely. However, in ASLD guideline, the surveillance in F3 patients is not recommended, and only F4 patients, the surveillance with ultrasound plus minus AFP every 6 months is recommended indefinitely. And the fibrosis stage recommended to be evaluated using FibroScan or other non-invasive tests. For the evaluation of event risk after SVR, I think these fibrosis marker of the liver should be checked: FIB4 index, M2B PGI, and type 4 collagen 7S. And also, if the patient have liver cirrhosis, the evaluation of portal hypertension is also important. So evaluation of esophagogastric varices by endoscopy and evaluation of post-systemic shunt by CT are considered. This graph shows the change of FIB4 index after SVR. The red bar indicates a percentage of patients with high FIB4 index equal to or more than 3.25, and blue bar indicates patients with low FIB4 index less than 1.45. So after SVR, more patients, in more patients, the FIB4 was decreased, and in less patients, the FIB4 is high. So at each time, the FIB4 index stratifies the HCC risk. So if the FIB4 index reduced, the HCC risk also reduced. And if the FIB4 is still high, the patient is considered to have high risk of HCC. So we should evaluate its FIB4 index after SVR at each time point. Regarding coffee consumption, the intake of coffee reduces the risk of liver fibrosis. Before HCV cure, the coffee consumption reduces the risk greatly, and even after HCV cure, coffee consumption reduces the risk of liver fibrosis. So we should recommend coffee even for the patients after SVR. And usefulness of M2B PGI was reported to predict HCC and survival in post-SVR patients. In this paper, if the M2B PGI was more than 2, the patient were easy to develop HCC. And also the patient with low M2B PGI, the survival after the SVR was high. And this paper shows type 4 collagen 7S was useful in post-SVR patients. The type 4 collagen 7S was reduced at the time of end of treatment and SVR 12. And if the patient the decreased type 4 collagen, the all-cause mortality was decreased. And also, the HCC development was lower in the type 4 collagen decreased patients. Recently, from Hokkaido University, angiopoietin-2, ANG2, predicts liver fibrosis non-regression after eradication of HAV. If the patients have F3 or F4 fibrosis, the non-regression patients have the higher ANG2 levels. And if the ANG2 level was more than 354, the patient with non-regression of fibrosis was higher than the regression patients. ANG2 is an antagonistic ligand of the vascular specific receptor type 2, which controls vessel maturation. In this paper, using ANG2 knockout mouse, vascular leakage was reduced. So if the ANG2 level was increased, vascular leak is induced and inflammation is enhanced. Also, baseline ANG2 predicts occurrence and recurrence of HCC after eradication of HCV. In ANG2 higher patients, the HCC occurrence was reduced, and also HCC recurrence was reduced. So if we can test this ANG2, we can evaluate the risk of HCC after SVR. This shows HCC surveillance strategy. We should assess not only fibrosis, but also HCC risk directly using HCC predictors, elastography, biomarkers, time after SVR, and age. These are taken into the HCC risk model, and risk should be stratified. If the patient has high risk, in this paper, abbreviated MRI is recommended. Abbreviated MRI is a shortened protocol of MRI. And if the patient has medium risk, biomarker panels and ultrasound is recommended. If the patient has low risk, only biomarker panels is recommended, and if the patient has very low risk, no surveillance is recommended. So we should take into consideration of cost effectiveness. And if the patient has cirrhosis, portal hypertension should be cared after SVR. If the patient has a major feeding vessel, the aggravation of esophagogastric varices was increased. And also, the patient has portosystemic shunt, the incidence of encephalopathy was high. So we should check the feeding vessel of varices or portosystemic shunt. And there was no change of such shunt diameter in 2 years. This report shows after SVR, the shunt vessel, like left gastric vein, post-gastric vein, short gastric veins, there was no change of the diameter after SVR. So if such shunt was formed, the shunt remained after SVR. This is a picture of recent autumn sky. In Japan, these clouds is compared to 30. But in English, such a sky is compared to mackerel. Mackerel is saba in Japan. Anyway, there are barriers to achieving the goals for HIV elimination. Lack of effective HIV screening strategies in rural areas and in low economic countries, and poor linkage to care in special populations such as drug abusers, sex workers, and MSM. Need for linkage to care for already known but untreated HIV-infected subjects, and the strategies needed to reduce or prevent reinfection in high-risk populations, and poor health knowledge of HIV infection and its management that lead to low screening rate in the general population, and variations of medical resources in different countries to engage in HIV elimination program. This is a result of a simulation of HIV and HBV-infected patients in Japan. The number of infected patients are estimated to be increased, but many patients are still undiagnosed or diagnosed but not linked to care. So we have to find such patients and link to care. So in this paper, ReLink programs was reported for re-engage diagnosed but untreated patients. 50,000 patients were screened and 12,000 patients were eligible, and 300 patients were relinked, and after that 700 patients were treated with DAAs. This program was performed in USA, France, and Brazil, and response rate was different by contact method. The patient was contacted with letter. The response rate was high in France, and the phone call was effective in USA. So we have to try such different methods to relink patients. So I'd like to introduce hepatitis medical care coordinators in Japan. To achieve the elimination of HIV, such steps is required. So screening step, detailed examination step, and treatment step, and follow-up step. So in each step, the coordinator helps the patient with different occupations. So such coordinators hoped to help the patient and promote HIV elimination. As summary, pan-genotypic DAA for HIV is now available, and global elimination of HIV is ongoing. When DAA is prescribed, drug-drug interaction should be cared. And after the eradication of HIV, patients should be followed up with a consideration of event risk, including HCC. Thank you for your attention.
Dr. Inoue, thank you very much for an interesting presentation. Now let's have a question and comment from the floor. Dr. Kakisaka, please.
Thank you for a nice presentation, Dr. Inoue. I'd like to ask you about how we can find the patient with non-treated HCV who did not visit the hospital. So we have to identify the patient, such a patient, to decrease actual zero HCV infection. And how do we identify the patient? Do you have any idea?
Thank you for the question. So you mean if the patient was already tested?
No, we have to find a patient with HIV who did not visit the hospital. So how do you find?
So the patient who did not
Visit
tested.
Yeah, right.
So I think it is a very important problem. So we have to test more person in each area. So we have to tell the importance of HCV infection to the persons and promote the test in each area, also in each workplace or something. But it needs very big effort. So
Yeah, right.
it is a big challenge for us. So let's
Yeah, we can. Thank you.
let's try together.
Okay. May I ask a question? What is the timing of introduce the EAA in the HCC complications? What do you recommend?
Thank you for the question. As an optimal option, the DAA treatment should be done after HCC treatment. After the HCC cure, the DAA is proved to effective for the survival. But if the HCC is still viable, that is, there was no real data to improve the survival. So we should consider the application carefully. If the patient condition is good and the prognosis is estimated to be good, I think the DAA should be prescribed for HCC patients. But we need careful judgment.
Yeah, okay, thank you. And next question. How many points of child peer score can be treated with DAA in child C class C, 10, 11, 12?
So you mean the limit of
Yeah.
stage
Upper
for
limit. Yeah.
DA treatment?
Yeah.
I think that is not only the child peer score, but also the patient's general condition should be considered. So I think there is no limit of child peer score, but if the patient is estimated to have very short survival, like several months,
Yeah.
I think the DA should not be done. But the patient is expected to live more than a year or so, we can consider the DA treatment.
Okay. Professor Omata, please.
Yes, Sorry, this is not a question, this is a comment that the question raised by the floor about the total elimination of this particular virus. The WHO claimed that the target year is 2030, but it's not a rabies. Rabies is a fatal disease, so naturally it's eradicated or eliminated, but this is a silent killer. So how do you claim this can be accomplished, elimination to 2030? So that's a big challenge, and maybe this might be the question, but what kind of the tactics or strategy you may have for the area in the northern Japan, Tohoku areas? You are the located in Sendai and Tohoku Daigaku. So how do you think about it? That's the question he raised.
Thank you for the very important but really difficult question. So, for the elimination of HCV, we need very big effort, but we are going on track for the goal of WHO.
Okay.
So
I have a couple of ideas, so maybe we can get together to work with and then tell the people in the Gilead as well. Thank you very much.
so please tell us such a strategy.
Is there any question, comments? Okay, I'd like to thank you, Dr. Inoue, for your interesting presentation. This session is now closed. Thank you very much.
Thank you very much, Dr. Kuroda and Dr. Inoue.